Well, welcome everyone. I'm Chris Fanta, and it's my pleasure to welcome you to our Asthma Grand Rounds program today. That includes those of you who are joining us by live webcasting. And I did want to point out that those of you at your computer or tablet, that you can submit a question at any time throughout the presentation. Just text it to the number shown on the screen here, 617-513-6043. Text us a question and we'll put it to our speaker at the end of the presentation. So I'm very much delighted to introduce Dr. Melissa Suter as our speaker today. Dr. Suter heads the Suter Pulmonary Optical Imaging Laboratory at Mass General. She's a member of the Pulmonary and Critical Care Division at Mass General. And we first heard about endobronchial optical computed tomography about 2 years ago at an Asthma Grand Rounds presentation here by Dr. Jocelyn Cho, as she was talking about her research into allergic asthma and allergy without asthma. And we've been eager, it's been 2 years, eager to hear more about this technique and what's exciting applications to asthma and the study of airways. So it's wonderful to have it from the developers of this technique, Dr. Melissa Suter, to speak to us today. Thanks for being here.
Thank you very much. Thank you so much for having me here to speak to you today. I'm really excited to present this work that we've been doing in my lab and some others have been doing, other labs have been doing on endobronchial optical coherence tomography. So here are my disclosures. So we all know that the prevalence of asthma is increasing rapidly, and it's associated with a staggering socioeconomic burden. And what makes it difficult to study is that it's not a single disease, but instead it's a heterogeneous group of multiple phenotypes. What we do know is that bronchoconstriction through airway remodeling and through excessive contraction of the smooth muscle is responsible for many of the symptomatic aspects of asthma. But there's no way to directly visualize airway smooth muscle structure and function in patients directly, which may be a key contributing factor to our incomplete understanding of the underlying mechanisms involved. So when we first set out to do this work, our goal was to see that if we could develop and use an optical imaging platform to enable us to perform in vivo microscopy, to assess airway remodeling, to assess airway smooth muscle mass, to look at its distribution in vivo, and also to assess the contractile force of the smooth muscle itself. So this is just an outline of the talk. I want to give you a little brief introduction to optical coherence tomography because I recognize many of you would not be familiar with it. Then move on to talk about some of the newer stuff that we're doing with birefringence microscopy that's also an advanced OCT technique that allows us to look at the smooth muscle structure and also to look at its function. And then I'll move on and spend the majority of the time talking about what we've done in our clinical studies using this technique, assessing airway remodeling and how it correlates to lung function, and also looking at the response to allergen. And then finally, we'll end with looking at where I think the real clinical utility potentially of OCT in asthma is for monitoring therapy, particularly in bronchothermoplasty, where we can potentially phenotype patients to select those that are more likely to respond to BT treatment. So what is optical coherence tomography? In its simplest term, it can be thought of as the optical analog of ultrasound. Basically, instead of sound waves, we're directing light into the tissue and we're measuring the amount of backscattered light. So essentially, we can create cross-sectional images of tissue microstructure by scanning the light across the tissue. It's much higher resolution than ultrasound, and it's similar to looking at a microscope slide at 2 to 4 times magnification. And what that really is appearing up here, is approximately 10 micron axial resolution and between 10 and 30 micron transverse resolution, depending on how we design our catheters. One drawback is that we're limited to about 3 millimeters penetration in lung tissue. However, because there's so much air in the lung, this is kind of similar to ultrasound anyway because it can't penetrate through air. It's non-destructive. It does not require a transducing medium like ultrasound does. There's no ionizing radiation like CT, and it relies purely on endogenous contrast. So the images that we collect in real time are these cross-sectional images that are displayed here. What you're seeing, the concentric circles in the middle are actually the catheter itself, which here in this instance is 0.8 millimeters in diameter. And we're doing spiral cross-sectional imaging, similar to radial EBUS. And the catheter is placed in the airway periphery down here. It's blown up here in this green box. And you can see we're looking at a longitudinal reslice here. You can see clearly through the airway wall into the surrounding parenchyma. These are the alveolar sacs, these dark regions here. You can see bifurcations here too. And as we pull back, this 10 centimeter pullback, we come up to some of the larger airways. We can better make out the layered structure of the airway wall. We can see the epithelium, the basement membrane, the lamina propria, the cartilage. So we're really getting very detailed images very fast. This entire 10 centimeter volumetric pullback was acquired in 5 seconds. So OCT, endoscopic OCT in general, was primarily developed with cardiovascular and GI applications in mind initially. And so the work that was done endobronchially in the lung was primarily focused on lung cancer, the early work looking to see if we could detect and diagnose lung cancer, early squamous cell cancer, if we could diagnose adenocarcinoma. And more recently, we've been looking at assessing pulmonary fibrosis and developing new smart biopsy tools to allow us to get to the periphery of the airway. But the early work that was done focusing on asthma was primarily done looking at airway dynamics. OCT is a really rapid imaging technique. So we were leveraging this great temporal resolution in order to see how the airway moves during normal tidal breathing or in response to various airway maneuvers, such as breath holds at end inspiration here in various airways, dependent versus non-dependent airways. And other groups as well were looking at it to look at airway wall thickness and compare that to CT. This was a really nice study done by Stephen Lamb's group where they were using OCT to see if they could accurately assess airway wall thickness. But I think that we were potentially missing the real benefit of OCT, and that's really high resolution. It's high structural spatial resolution, which is highlighted in these two images here that were obtained from a human volunteer. On the left one here, you can see the nice layered structure. We've got this epithelium, which is this moderately scattering layer over brightly scattering basement membrane. Here's a mucosal duct that this arrow is pointing to. We see this region of the lamina propria where we know there is some smooth muscle, there's some vessels, there's some glandular structures, and then we have a perichondrium and cartilage. And in an asthmatic airway on the right, we're seeing the consequence of the smooth muscle. We're seeing clearly the smooth muscle is trying to contract the airway, and as a consequence of that, we're seeing this mucosal buckling up on itself. But really what I wanted to point out here is with normal structural OCT, we can't really see the smooth muscle, which is what we really wanted to do in asthma. And this led us down this track to develop this new imaging technique that will enable us to actually see that airway smooth muscle and also get an idea of how actively that smooth muscle is contracting, you know, the internal stress of the smooth muscle. So when I was first faced with this problem, we were trying to think how can we add additional contrast to this tissue? And we basically went back to really simple principles that if tissue is really highly organized in one direction, then the orthogonal directions of that tissue are going to have a different refractive index, essentially, depending on the light. So we know that if we pass light through that, the orthogonal polarization components of the light will have a delay with respect to one another. And we decided that we could potentially leverage that to provide additional contrast to the tissue. We know that airway smooth muscle is really birefringent. We know that from many decades of research before, that it's organized into tight bundles that wrap around the airway. So if we could leverage that ordered structure, we might be able to provide additional contrast. And these are the very first images we obtained to try and demonstrate this. And what you're seeing here is a piece of swine trachea which we've essentially just taken a small segment out, we've cut it open, so we've laid it flat, and we're imaging it with a benchtop imaging system. And here is our normal structural OCT image that we would see. You know, you've got your layered structure, the epithelium, lamina propria, other tissues here, which we do know include the trachealis muscle, given it's the trachea. And on the right, we've overlaid that with the optical retardation, that the magnitude of that delay that we saw in the orthogonal polarization components of the light. And you can see that that nicely provides additional contrast here to pull out or highlight organized tissue. Now, it's also going to highlight collagen, which is why you see a lot of birefringent tissue here. So we have a picoserous red stained histology slide here highlighting all the collagen, and alpha smooth muscle actin stain histology slide here highlighting the smooth muscle. But we were very encouraged by this and, you know, wanted to see if we could take that a little bit further. And I mentioned that the tissue has, that birefringence, that retardation has an angle associated as well as a magnitude. So it's not just how much it's delayed, but we can tell the orientation of the tissue, the way that that's ordered. And so we know from just general knowledge that the airway smooth muscle is organized into these bundles that wrap circumferentially around the airway. So we know that it has this main orientation. So if we pull out just a circumferentially oriented birefringent tissue, we're able to really nicely isolate the airway smooth muscle layer here, as opposed to looking at the longitudinal component, which is primarily the collagen. So our big challenge was, how do we do that in a catheter? I mentioned that we do spiral cross-sectional imaging. This is this is a photo of one of our imaging catheters here, where we have an optical fiber inside this sheath, and this spins rapidly at 60 hertz and pulls back. So there's a lot of moving parts. The fiber is moving around, but that's going to cause havoc basically with the polarization state of our imaging system. So we had to come up with a way to try and compensate for that. And it was actually he's now in a junior faculty in my lab, but at the time a postdoc in the lab who realized that we could leverage the birefringence of the sheath that we're imaging through. Although it's almost transparent, the polymers align themselves in the direction of extrusion. So it does have some birefringence as well, and we could use that to calibrate the system so that we could essentially resolve the circumferentially oriented optical axis. And that was a real breakthrough. This is just a validation of that. We have a stretched rubber phantom over this metal disc here. And you can see that we nicely can make out the longitudinal versus the circumferential orientation of the rubber phantom. But this was a big advancement in OCT imaging of birefringence in vivo. And so this is an example of some of the images that we were able to collect in vivo. On the left, you have your normal structural images. This is of a healthy volunteer. And, you know, you can see that in some regions you could potentially guess where the smooth muscle is, but really structural OCT just doesn't have the contrast that we need. But on the right, we've overlaid the circumferentially oriented retardation, basically, so that we can highlight where the smooth muscle is nicely. And this is just a zoomed-in version of that to, again, see that although, you know, in some instances you might be able to guess where the smooth muscle it is, it really isn't that easy. So now that we had this technique, we wanted to be able to validate that. And one of the things we did is we dissected 1 centimeter segments from swine and canine lungs. And we imaged them volumetrically, that intact segment, with our imaging system. And we then, at 15 micron spacing, and then we then sent that segment off to pathology, and we were able to get histology slides that we could match back to our structural OCT. We then sent both data sets, the orientation resolved OCT highlighting the smooth muscle, and the histology off to blinded individual readers, and we had them hand trace the smooth muscle, and we found a really great correlation with the amount of airway smooth muscle in these. This is 162 airway segments done here, 82 swine and 80 canine. And you can see that the correlation between the OCT amount of smooth muscle and the histology were very nice, with basically no bias at all. The next step was to validate that in vivo. And so we conducted a study in canines, and we imaged them in vivo. We took the lungs out, we fixed them, and then we did that same process of trying to match back the histology to the OCT images and had blinded readers interpret them. And although the accuracy went down, which I'm going to talk a little bit more about later on, I think this is largely due to the orientation of the catheter within the airway and inflation size and things. We still got a very nice, significant correlation. So I mentioned that we can see airway smooth muscle. So now we can see airway smooth muscle in vivo for the first time, which was not possible previously, to visualize it volumetrically in patients. But I also said that we could get an idea of its actual function, measure its contractile force. Now, if you remember to that slide I was showing you the teeny bit of physics where we were looking at the orthogonal polarization components of the light and how it undergoes a delay with respect to everything, with one another. The results that I've been presenting showing you the airway smooth muscle itself, the airway smooth muscle mass, was done purely by looking at the orientation of that signal. But if we look at the magnitude of that signal as well, we can get an idea of how densely that's compacting, and we hypothesized that that would relate to how much the smooth muscle is contracting. And so to test this hypothesis, we once again went back to freshly excised swine tracheal segments. Again, we took a small, probably 1 centimeter or less segment. We bisected it, so we opened up that circular segment. We attached one end to a stationary pin and the other end to a force transducer. And then we put our imaging system in a benchtop configuration, and we essentially just scanned that piece of tissue while we applied methacholine, so while it was actively contracting. On the right, you can see these images. The grayscale is the structural OCT image. The color-coded portion is the airway smooth muscle, and it's color-coded according to the amount of retardation. So that's basically presented in degrees per 100 microns. And this is what we got from this very first experiment, which we were very surprised about. So that local retardation, that amount of that magnitude of that phase delay essentially, was plotted here in black against time. So we've got this across here. And in red, you've got the force of contraction as measured by that force transducer in time. And you can see that they nicely track one another. So we repeated this a number of times, and we found a very consistent relationship between the force of contraction and that retardation that we were measuring. The slope did differ amongst the various samples, but when we basically accounted for the cross-sectional area of the airway smooth muscle, we found a very consistent relationship between the stress and the optical retardation, essentially giving us this coefficient that we can apply to our in vivo data sets to actually pull out, the force of contraction. And so to test this, we went back to an enclosed segment of airway. This is, again, freshly excised swine airway segment. And on the top, you have at baseline, and on the bottom, you have after we've given it methacholine. Now, this is a volume rendering. You can see in the grayscale, so that's that 2.5 centimeter pullback rendered in grayscale. And in color, we have the thickness of the airway smooth muscle. And that's plotted from 0 to 58 microns in this case here. And the reason we did that is because it helps you to better appreciate the banding structure of the airway smooth muscle. You can see it arranges itself in rope-like bands that wrap around the airway. Then on the right, we have that retardation, and that's plotted from basically a really weak signal, which is in blue, up to a stronger signal in red. So we've got baseline and then following methacholine. Now, if we assume that this is a thin-walled cylinder and we use that relationship we previously determined between the optical retardation and the induced stress, we can calculate a force of contraction in result of the methacholine of 17.4 centimeters of water. And this also came with a 10% reduction or 9% reduction in lumen diameter, minimal change in airway smooth muscle thickness, but a big jump in the birefringence that we measured. We weren't sure if this, seemed reasonable or not, so we went back through the literature and we found that if we looked at airways of similar size. We looked at concentrations, similar concentrations of methacholine. We found that our results were very consistent with much older studies that were previously published. Many people ask us what we think that the rise, what's causing this retrogradation signal. And the first thing that we sort of looked at was we assumed that either on the larger scale, those ropes that wrap around were realigning themselves and becoming more ordered in the circumferential direction. And this is one thing that we looked at, and we saw that as it contracted, they became more perfectly circumferentially orientated, as opposed to maybe plus or minus 30 degrees from that circumferential orientation. But we also looked closer at that and thought, well, potentially maybe we're actually seeing something with the airway smooth muscle itself. And this is an image that we collected to try and validate this, although this work is still ongoing, where we looked at the orientation of the airway smooth muscle in just a single cross-section here. So this is displayed on FAS up here. And at baseline, you can see a lot of change in color, which is representing that there is some variation in the angle of the orientation. But as it contracts, it becomes more homogeneous and more red, meaning that it's more perfectly circumferentially oriented at 0 degrees. And so we believe that potentially this could be a result of the action of the smooth muscle itself. So that was my, unfortunately, big introduction into our imaging technique and what we've been doing and how we've been trying to validate that. But I wanted to move on to some of the results that we've had in patients. And this is a study that we did with Ben Madoff at MGH, where we were looking at, and Andy Luster, sorry, where we were looking at individuals at baseline, and we were bringing them back 24 hours later to look at their response to allergen. So I'm going to present a subset of the results here from that we collected from mild asthmatics. So we had 20 allergic asthmatics. These were very mild asthmatics. 22 allergic controls. They were allergic, but they did not have asthma. And then 3 healthy controls. And I just put there this up here so you can see that these were very, very mild asthmatics. And some of the metrics that we looked at, the OCT imaging metrics that we looked at, were mucosal thickness. So that was measured from the airway lumen to the edge of the cartilage here. We looked at epithelial thickness, which is that top moderately scattering layer that we showed previously. We looked at mucosal buckling, essentially, that you can see here, the airway sort of buckling up on itself as a result of smooth muscle contracting. And we also looked at mucus heterogeneity. And here are some of the baseline results that we saw, the differences between the two. We saw, even in these very mild asthmatics, there was significant airway remodeling at baseline. The mucosa was much thicker than the allergic controls or the healthy controls. The epithelial thickness was also thicker, and probably not surprising, the allergic asthmatics had a lot more buckling compared to the other two. When we looked at mucus heterogeneity, this was interesting, and we saw that although that there was a lot more stuff in the mucus of the allergic asthmatics compared to the allergic controls and the healthy controls. Whether that was cellular debris or something else, we're still unsure about. But the big difference came when we looked at the airway smooth muscle. So here we have the healthy control, the allergic non-asthmatics, and the allergic asthmatics on the very right. And what we're looking at is that 2.7 centimeter pullback, that volume rendering, where we've color encoded airway smooth muscle thickness again from 0 to 120 microns. And then beneath that, we're showing that circular cylinder essentially unwrapped and laid flat, so you can get a better appreciation of the banding structure of the airway smooth muscle and what's going on. And you can just see from this, even these very mild allergic asthmatics had a lot of airway smooth muscle remodeling compared to the others, which essentially was double the airway smooth muscle width and the airway smooth muscle thickness. By airway smooth muscle, I mean the band width and the band thickness. And what was interesting, we found again that this directly correlated with pulmonary function. Mucosal thickness correlated with a decline in pulmonary function, epithelial thickness, and not surprisingly, mucosal buckling was very correlated with this as well. So Although, you know, some of these differences may seem minor, that had a big difference on the pulmonary function. So this is just a summary of these baseline differences that we observed. The allergic asthmatics had a lot greater epithelial thickness, mucosal thickness, a lot more mucosal buckling. They had something going on in their mucus. And, of course, the airway smooth muscle was significantly greater. But I mentioned that these patients or these volunteers were coming in for a segmental allergen challenge. So this is the protocol that they went through. They came for baseline visiting where they had their PFTs. Then they came in for day one where we did our OCT imaging of the right middle lobe, the right upper lobe. We got a baseline lavage of the lingula. And then we gave them an allergen in the right middle lobe, and we gave them a diluent in the right upper lobe. And we brought them back 24 hours later, and we re-imaged them again, and we collected cells from the lavage again. This slide here is just showing that the results from the lavage, we didn't really see, at least in total cells and eosinophils, much difference between the two allergic asthmatics at baseline and 24 hours following, and allergic controls or non-asthmatics at baseline and 24 hours following. They both seem to respond in a similar fashion. And this is a busy slide, but this summarizes what we saw with the OCT metrics here. Concentrate first on the mucosal thickness. The right upper lobe was the lobe that just received the diluent control. And you can see there was no real difference from day 1 to day 2 in any of the groups. There was a difference from between the groups, however. But in the right middle lobe, where they received the allergen, you can see a marked increase in mucosal thickness from day 1 to day 2, both in the allergic asthmatics and in the allergic controls. And as to be expected, nothing really in the healthy controls, as they weren't allergic to what we gave them. And this was a similar trend in the epithelial thickness as well. No changes between day 1 and day 2 in the right upper lobe that had the diluent, but a big change in the epithelial thickness between day 1 and day 2 in both the allergic asthmatics and the allergic controls. What was interesting was when we looked at the mucosal buckling, that essentially kind of looking at a consequence of the smooth muscle contracting. And we can see that, yes, the allergic controls did have an increase in mucosal buckling in response to the allergen, but we also saw that increase in mucosal buckling in the allergic asthmatics just from doing the bronchoscopy, just from having the diluent. Those airways closed up as well. So maybe indicating that the smooth muscle there is a little bit more twitchy in the asthmatics compared to the allergic controls. And then I pointed out the mucus heterogeneity was interesting as well. We saw a difference to the allergen in mucus heterogeneity in the asthmatics, but nothing in the others. Which was interesting. And this just highlights that junk in the mucus that I'm talking about. On the left, this is an allergic asthmatic rendering. On the left, we've color encoded the mucus in yellow so you can better see it and highlight it. But you can see baseline, there is some stuff in it, but it's sort of homogeneous. But in response to the allergen, there's something going on here that doesn't sort of reveal itself in the total cell count in lavage or in the eosinophils. But not surprisingly, the smooth muscle is where we saw the great difference, which would have been indicated also by the mucosal buckling. On this slide here, on the left, we have the allergic non-asthmatics, and on the right, we have the allergic asthmatics. Again, we've displayed the circumferential, or the 2 to 3 centimeter segment. We've unwrapped it and laid it flat so you can better see the smooth muscle. And we've color encoded it here. This pink color is from 0 to 120 microns in airway smooth muscle thickness at baseline and following allergen for the non-asthmatics, and at baseline following allergen for the asthmatics. And then we've also displayed the birefringence, or the local retardation, and we've plotted that from 0 to 56 degrees per micron, again at baseline and following allergen. And immediately, just looking at this, you can see again the allergic asthmatics have a lot more smooth muscle compared to the allergic non-asthmatics. And they also appear to have greater baseline tone compared to the non-asthmatics. This image here is brighter. It appears that there's more stress in the airway smooth muscle band itself. And of course, that increases dramatically following the allergen. And that's the results of the few that we did are summarized here. In general, we saw an increase in both the stress for the airway smooth muscle in the non-asthmatics and asthmatics, but it was double in the asthmatics compared to the non-asthmatics. And that twice the internal stress resulted in a much greater closing of the airway. The radius closed down 10% or 11% compared to like 1.6. And we did see a change in the airway smooth muscle thickness, likely just conservation of mass. The airway's getting smaller, everything's coming in. So this slide here just summarizes the results, these ongoing results from these studies. We see a lot of difference at baseline. We see that the allergic asthmatics have significantly thicker epithelial layer. They have significantly thicker mucosal layer and a lot more mucosal buckling compared to the allergic controls. We also see something in mucus heterogeneity. This is something we're clearly going to have to go back and revisit, but there's something in the mucus there. And of course, there's a lot, the airway smooth muscle layer is a lot thicker. And this results in a lot more contractile force of the airway smooth muscle and a closing down of the airway. So just to summarize from this clinical study, we now have this technique that allows us to not only look at tissue microstructure, but also its potential function. We've seen early remodeling in these very mild asthmatics, and that this early remodeling has a significant impact on the pulmonary function. And what was interesting is that although the allergen elicited a similar response in both the lavage and microstructure of the groups, the big significant difference in mucosal buckling indicated that it's likely airway tone is the defining difference, at least in what we were observing between the allergic asthmatics and the allergic controls. And that's also supported by the preliminary work that we did looking at the airway smooth muscle directly. So that kind of summarizes the research side of the work that we've been doing using OCT to look at the asthmatic airway. But we're also, I believe that a big opportunity for clinical utility for this is in phenotyping patients, potentially selecting patients that are more likely to respond to thermoplasty, imaging patients after thermoplasty to see whether the technique itself was successful. Was there a reduction in airway smooth muscle or not? And so we set out to first do this study to see if we could see a reduction in airway smooth muscle. If you remember early on, I mentioned that collagen is also a birefringent tissue. And we know that once that in response to thermoplasty, once the airway smooth muscle sort of is reabsorbed or dies or goes away or whatever happens to it, that there is collagen in its place. And so we wanted to prove that we could actually differentiate between collagen and the smooth muscle. So we conducted this study. This was sponsored by Boston Scientific in 8 dogs. We did bronchial thermoplasty in one lung of each of the dog. We imaged up to 26 sites per animal. The sites were based on those that they would treat by thermoplasty. So they were greater than 3 millimeters in diameter. And they were approximately 5 millimeters in length. So we had each distinct sites, and we documented them between bifurcations so that we knew exactly where to go back. We performed imaging at baseline. Then we brought them back. We did imaging at 21 and at 42 days post-treatment. And then following sacrifice, the lungs were excised, they were formalin fixed, ideally to a pressure of 30 to 40 centimeters of water, but I'll talk a bit more about that later. I'm not sure that happened with all the animals. And then we did the same sort of matching technique we did before, matched the OCT and the histology, and we had blinded independent reviewers essentially look at the amount of smooth muscle in each. So I showed you this slide already. This is the untreated airway. This is just looking at, can OCT see the airway smooth muscle? And you can see, compared to ex vivo, there is smooth muscle here, but these animals, for some reason, did not have the smooth muscle we were expecting to see. It was ironic because Boston Scientific really wanted us to do this in dogs because they have more airway smooth muscle, but these guys didn't for some reason. But we still got very nice correlation between the two. And then if we look at the airways following BT treatment, so these were 42 days after treatment. These are the images we saw here. We've got, again, the OCT image on the left with the airway smooth muscle highlighted in red. We have alpha smooth muscle actin stained here where we can see the smooth muscle here in pink. and then we have the trichrome, Mason's trichrome image here. And the correlations were very nice again here. But if we zoom in, you can better appreciate how thin this is, we're talking. The thickness of the smooth muscle here was pushing 10 microns, which is really what we state is our resolution limit of OCT. So we were very happily surprised that we still managed to do a decent job in seeing the OCT in these eyes. In humans, you saw previously, the smooth muscle is going to be much, much thicker, more on hundreds of microns thickness as opposed to the 10s here. But this is a summary of all of the data points from baseline following treatment at 21 and 42 days here. And you can see that we did get very nice consistent results between the OCT amounts of airway smooth muscle and histology and all significant results with little bias. And I like these volume rendering images because you can better appreciate what's going on here with the smooth muscle and these unwrapped layers. These are bifurcations, these black holes, by the way. This is a region of airway smooth muscle that was untreated, and the mean airway smooth muscle thickness here was 25 microns. And this is following treatment, and the mean thickness was 10 microns. Again, just pointing out that really this is right on the resolution image limit of our imaging system. So we were still pretty impressed that we were able to do it. So all results that we got were statistically significant. We did find that on average, the OCT measures of airway smooth muscle were less than that on histology, but we think this is also largely due to a fixation. We did this study off-site at an off-site animal center so that they handled the tissue fixation for us, but we know that the lungs weren't fixed according to our protocol because the way we excised them, we went back and we did a bronchoscopy on the fixed lungs to go back to those exact same targets to pull out the same bifurcation points that we had, and in many cases we really struggled to get the bronchoscope in there, so we do know that things were a little bit different. Another limitation was the registration mismatch. When we have the segments of airway excised already before we image, we know that we can place our catheter perfectly in the middle, so it's so that if we cut circumferentially, do the histology slides, they're going to match up well with our imaging. But in vivo, that's not the case. Often the catheter's on an angle, it's against a wall, it's gone multiple bifurcations. So there was some alignment issues there. And I mentioned that the smooth muscle was much thinner than we expected. So we were happy with this, though. Boston Scientific was happy with this, though. The NIH was happy with this, though. So now we're moving forward with a multi-site clinical study that we are in the final stages of getting approval for. We're planning to do this at MGH and at Beth Israel, and we have the MGH approval and we have most of the Beth Israel approval. It's just getting them to approve each other's and the NIH to approve too. fun stuff. But basically what we want to do is see if we could monitor the effects of thermoplasty in asthma with the goal of predicting the clinical response. Potentially looking at different phenotypes of asthma. Is it more an airway smooth muscle driven one, or is it more an inflammatory driven one? Look at why treatments are ineffective. Was it just the treatment itself? We found that in our animal study, we noted that in some regions where we thought it was treated, Boston Scientific, the clinicians said it was treated, we saw no change in airway smooth muscle. So maybe, there's some user error there too. And potentially maybe some asthmatics are just so prolific at airway smooth muscle remodeling that even though you do treat it, even though they do get rid of it, it just grows back again really fast. We don't know. So we potentially want to see if we can use our imaging technique to basically give us more insight into this. And so the study that we've planned is outlined here. Basically, we have baseline testing. Then they have the normal 3 treatment points, BT treatment points, and we plan to image at each of these points. And then we plan to bring them back again 12 months later and image again to see what we see. Our testing will include spirometry, methacholine, CT, bronchoscopy with lavage, obviously our OCT imaging, not only looking at the amount of smooth muscle, but how twitchy that smooth muscle is as well, how the baseline tone of that smooth muscle, and the asthma quality of life questionnaire. So we predict that those subjects benefiting most from BT would be those that have more airway smooth muscle at baseline, which is kind of sort of intuitive. So basically, just to summarize, OCT's been around for a while now. Like I mentioned before, it's been used extensively in GI. It's been used extensively in cardiovascular studies, dermatology studies, ophthalmology. Everyone's seen it, ophthalmology. But it's starting to really get some traction in pulmonary, specifically for lung cancer, IPF, and more so now with asthma, that we have these additional techniques that enable us to see the airway smooth muscle, which we've validated. And we've also, there's still more work to do, but we have this new technique that will give us insight to the airway smooth muscle tone and the potential for contraction. And basically, we've performed imaging in a number of human volunteers, and we've demonstrated that, again, the mild allergic asthmatics have significant airway remodeling at baseline, which we didn't really expect to see, and that is directly related to lung function. And our results sort of lead us to believe that potentially the airway smooth muscle is just more twitchy in the allergic asthmatics compared to the allergic controls. But we believe that this platform, this is just the beginning. This is just what we've been managed to do so far. We think that if we can get it out there, if we can get it into other labs, we can do other studies for it, we can potentially answer a lot of other questions about asthma and potentially use it to serve, in this case, use airway smooth muscle to serve as a biomarker for predicting, phenotyping and predicting response to therapy. And again, in the research side of it, figuring out what drives the differences between different asthmatics. So I can't end this without mentioning David Adams here. He's really done the majority of the work on the technology development and also the clinical studies, and he's been a real leader in driving this project forward. But also my other lab members, our clinical collaborators and funding sources. Thank you.
Thank you very much. How exciting, and I can see we need to invite you back now for about, what, a year or 2 years, and come back and share with us. So exciting.
Yeah.
I'm guessing that you'll get a look at patients with quite severe asthma when you do the bronchial thermoplasty.
Which is what we're really excited about. We're also looking at potentially spraying topically methacholine to see if we can image them at baseline and on individual airway segments, so we can see, what's going on there.
Segmental,
that's another milestone for getting approval to do that in patients, but that's our goal. We are also doing, starting now, a sheep model of asthma, where we're going to do that. We're going to give them asthma by sensitizing them and giving them allergen over 12 months or 6 months. Then we're going to treat some areas, and we're going to locally apply methacholine so we can get a better idea of, is it inflammatory response? Is it the smooth muscle? Like we'll have some on steroids so they get rid of the inflammatory component. And yeah, I'm excited to see and play with that.
Tweak them
right, yeah.
My sense is that bronchial, correct me if I'm wrong, is mainly sort of more central airways, but your catheter is like 1 millimeter.
Yeah.
So you can go deep into the periphery to image smooth muscle. Have you sort of looked at differences in peripheral airways and more central airways? And
we have, but more just qualitatively. We do see that, as is already published in literature, that the smaller airways have more smooth muscle compared to the other components of the airway, but less smooth muscle if you just look at the absolute thickness itself. And because they have less structural components like the cartilage holding it open, yes, they're more likely to close up. What we're excited to see is what the remodeling, the subepithelial fibrosis, how that changes those mechanics. Perhaps that's the body's way of protecting itself against closure. We're excited to look at that, but yeah, we haven't as yet.
Questions? Jeff, do you want to start? I'm sorry. Jeff Fredberg.
Thank you. Thank you.
So it really is an exciting technique that opens lots of doors. So a comment and a question. I've got a million questions. And a comment is in terms of how the technique actually works. You talked about how during contraction, the fibers or stress fibers can get aligned, but in smooth muscle, the actomyosin filaments are evanescent, and when you contract the muscle, they polymerize, and when you relax it, they depolymerize. So that would be another, I think, potentially important and maybe even dominant contribution to the birefringence.
Yeah, absolutely.
But there's a lot of literature about how these fibers polymerize and depolymerize.
And it's definitely outside of my expertise right now, and we're trying to sort of uncover that, hooking up with other people that are experts in the field like yourself or others to try and, our preliminary look at it is just looking at the bundles of smooth muscle, and we do see some change there, but we're also seeing some sort of birefringence change at sub-level there.
I think the alignment changes won't be enough to account for such a big
change, right, yeah.
Polymerization.
Yeah.
The question is that airway remodeling is a big deal. So you probably know, in Chamberlain in 2004, there was a Nature paper suggesting that bronchospasm by itself, in the absence of inflammatory cells, can drive remodeling. And then the Grange paper in New England Journal 2011 supposedly validated that in mild asthmatics.
Yep.
But that paper has been criticized, and a lot of people didn't believe the result. I mean, you've got the ideal tool.
Exactly.
Really look at that in detail in people.
And we would love, it's difficult to get approval because we hypothesize that it will cause airway remodeling, in people. But my personal train of thought based on what I've seen is that is true, that it's like bodybuilding. You work the smooth muscle out and it just basically gets bigger,
Yeah, well, they found the basement membrane thickened, goblets, the whole nine
host
yards.
of things, yeah.
If you can't get it approved here, you talk to them and do it in England.
Okay.
It's really an important question.
Yeah,
Whether
yeah.
bronchospasm itself drives remodeling, because people always thought about it the other way around.
Right. And we're at that point now where, the technology can be, for a long time it was just something that we could do in our lab, but, we're at that cusp of where it can be done elsewhere now too. So absolutely get it out there to get people doing research on it.
It's beautiful work and it's really fascinating. Two questions. One was, I wasn't clear. You looked at these allergic asthmatics and they had increased smooth muscle. And the allergic non-asthmatics versus allergic asthmatics, was the smooth muscle size the same, or was
it was so the smooth muscle was different. It was double.
Double.
In the the allergic controls and the healthy controls both had the same level. The allergic asthmatics were double.
And then have you had an opportunity to look at people who've been treated, and I'm not talking about bronchial thermoplasty, but let's say with inhaled corticosteroids, and see whether there's really a reduction in smooth muscle? Because that's one of the kind of holy grails of
Right.
trying to figure out what we're really doing
Yeah.
to reduce
Or
inflammation.
other epithelial changes, right? Epithelial thickness or
Right,
anything.
exactly. And CT has tried to approach this, but it's much less, I think, sensitive probably than what
Right.
we're doing.
Yeah. No, we haven't, but again, something that we'd love to do. The segmental allergen challenge study, we basically jumped on. That was ongoing already, so it wasn't necessarily something designed by us. It was, they have this, let's jump in on it too. But yeah, there's so much we want to do,
Great, thanks, Melissa. Finally, it's good to see you in person.
Thank you.
It's a great talk. And so my lab is studying the effect of bronchoconstriction in air remodeling. And then our recent paper showed that actually the epithelial cells drive smooth muscle contraction and a hyperproliferation in the buccal epithelium. So that's just one thing I want to talk to you. And another thing is, it's amazing you show that the mucus heterogeneity by using this technique, because it has been confirmed by David All's group using histology, immunohistochemistry. So there are two types of secreting mucus in the airways. It's mucin 5AC and mucin 5B. So probably that what you are seeing, the heterogeneity, is because of two different types of mucus existed in the airways. And when you do BAL, I think those are not quite soluble, so you don't see those in BAL, but I think it's amazing.
So we wondered that. We did do some preliminary results. We published a paper where we looked at the mucin content and this mucus heterogeneity, and it did correlate. But I don't know that that's the full story because mucin's transparent. So the fact that I'm not convinced yet that that's what we're seeing because, you know, I believe it's transparent, so.
Yeah, but it's the transparency, but they are viscoelastic. So when they have different component of mucin, MUC5AC versus MUC5B, their elasticity is different and stiffness could be different. So that's why you see those.
Yeah, but our structural OCT doesn't look at the stiffness. Structural OCT is just looking at the amount of backscattered light. I mean, maybe. I'm not convinced yet, you know, but like you said, we did see a correlation. So, you know, that's something we are talking a lot about and trying to figure out. But thank you, yeah.
I, for one, would like to know when these changes start.
Right.
I
Right.
don't know about putting your catheter in you know, infants and
Yeah.
toddlers and stuff, but boy, it would be fascinating and certainly small enough.
I agree. That's the issue with it. We require bronchoscopy, you know, and for just research purposes on young children, it's not. Yeah, but wouldn't that be great?
Well, thank you. What a stimulating presentation. Thank you so much.
Thank you very much.